options for patients in the third-line setting depend a bit on their molecular genomics. In patients that are MSI high, we have approved therapies now with Keytruda as well as nivolumab. So often, if they have progressed first and second line therapy and have not been exposed to immunotherapy, that's what we would consider. In our patients that are all RAS wild type, we think about anti-EGFR therapy, cetuximab or panitumumab with or without irinotecan. In our patients that are RAS mutated, which is roughly 50% of our patients, the options include a clinical trial of various either targeted agents, immunotherapy combinations. The large majority of our patients are MSS or microsatellite stable and do not benefit from single agent immunotherapy alone, in which case we look for clinical trials, of which there are several now ongoing, looking at combinations immunotherapy plus targeted agents, plus a type of stimulus that might stimulate the immune response. Or, of course, we have our standard approved therapies for the refractory disease, which include Stivagra and Lonsurf. For many patients, it's really about maintaining quality of life. So a lot of our decisions are what will give you the best quality of life. Of course, we also consider duration incredibly important, but it really is important for many patients that they suffer as few side effects as possible, are able to live a good quality of life, whatever the duration might be at that point.
We have two options today for our patients with refractory metastatic colorectal cancer, assuming that we don't have a clinical trial that's available, a clinical trial that's specific for colon cancer. Oftentimes we think about clinical trials as phase 1, non-specific. I think all these trials have their roles, but both TAS-102 and regorafenib are part of our standard and would be considered standard of care treatment options. The question is, how do you choose one versus the other? There is no data that's out there that compares one versus the other. So we do not have these randomized trials that inform us, teach us about which one to start with. We have some data here and there and some more emerging data from ASCO GI that gives us a hint about some kind of sequencing. For example, the RECOURSE trial that looked at TAS-102 versus best supportive care had about 20%, a little bit less than 20% of the patients who received regorafenib before they received TAS-102. And the benefit of TAS-102 was not compromised by prior exposure to regorafenib. So we know that it's a subset analysis, so certainly it's taken with a grain of salt. We also know that with regorafenib, there was a study called CONCUR from Asia that had patients with less pre-exposure to EGFR inhibitors and VEGF inhibitors. That study showed that regorafenib may actually have a larger level of efficacy if you have patients that are less pre-exposed. There's also a study that was presented at ASCO GI that looked at patients with regorafenib in earlier lines of therapy. It was a phase 2 study, but the results looked somewhat better than the historical correct. So all these are hints, and then we have the REVERSE trial that was also presented at ASCO GI that suggested that the sequence of regorafenib before cetuximab, rather than the other way around, i.e. starting with cetuximab and waiting on cetuximab to fail to go to regorafenib, produced a close to 6-month survival benefit, which was highly statistically significant. So when we take all this data and put it together, what becomes clear to us is that it's important to first expose patients to as many lines of therapy as possible. 2, it's very important to consider regorafenib as an option for patients at the time it's indicated, but not wait too long down or far too long in the therapy where you're likely to lose benefit. That's what we saw in REVERSE. It was very interesting. The loss of benefit was clearer as you go in a lower line of therapies.
When patients are found to be MSI high in colon cancer, we have 2 options now that are FDA approved for these patients in the refractory setting, including nivolumab and pembrolizumab. And both are FDA approved and both have been studied extensively. at this year's meeting, we saw some data with nivolumab showing long-term survival numbers, which are quite impressive. And pembrolizumab, we've seen that data before, and it's already published actually in several journals. So fundamentally, you have two options. And from my perspective, it's hard to distinguish between the two. They both have fairly equivalent response rates, fairly equivalent toxicity profiles, and we find that reassuring as oncologists when two drugs really have very similar clinical activity. So I confess the decision between nivolumab and pembrolizumab in this setting, in my opinion, is fairly arbitrary. It's based on features that are outside of the data, perhaps, and more based on individual practitioner preference and experience with those agents. So it's good to have two options. We happen to have two FDA-approved drugs for that indication. Both Nivo and Pembro are active and useful there. When we are used to giving checkpoint inhibitors, and now many of us are more so than ever before in colorectal cancer, which admittedly with MSI high is not very common and perhaps overstated in the literature. But if we assume that it's somewhere in the 4% range for patients with metastatic disease, and in particular, the use of checkpoint inhibitors in colorectal cancer, MSI, is really exclusively in the metastatic setting. And so we're looking at about 4%, let's say, of all comers that have true MSI. Some people report a little higher, some people report a little less, but we know that as patients progress through colon cancer, it's a little less likely to have MSI high. Now, when we look at toxicities of these drugs, again, there's not much to distinguish Nivo and Pembro. There's toxicities that are typical for any immunotherapy drug, which includes fatigue, of course. And then there are the immune-related side effects, which are also fairly indistinguishable between Nivo and Pembro, include the typical ones such as thyroiditis, which can occur, such as possible elevations in AST and ALT, and then some of the very rare but dangerous side effects, which include pneumonitis, pancreatitis, which has now been increasingly reported, and hyperglycemia, all of which seem to be somehow related to autoimmune type side effects, which when recognized early can be treated and require some management strategies in continuing those drugs.